Good afternoon, everyone. I am Ada Afshin on behalf of IGCP. I extend a very warm welcome to all our respected clinicians and participants joining us for today's special academic session held in observance of International Epilepsy Day. Today's topic is both clinically enriching and intellectually stimulating windows into clinical neurology, key pearls for clinicians. Neurology often represents as a specialty of precision where careful history taking, clinical examination, and thoughtful interpretation can unveil powerful diagnostic insights. On International Epilepsy Day, it is especially meaningful to revisit foundational clinical tools that help us recognize neurological disorders early and manage them effectively. It is a profound honor to introduce our speaker, Dr. A.V. Srinivasan. So, he did MD, DM, PhD, DSc, FRCP, FIAN, FAAN. He is Emeritus Professor in the Tamil Nadu Dr. MGR Medical University. He is the former President in Indian Academy of Neurology. Dr. Srinivasan sir is a towering figure in Indian neurology with decades of clinical academic and research contribution. His experience, scholarship, and mentorship have shaped generation of neurologists and clinicians across the country. We are truly privileged to have him share his wisdom and clinical insights with us today. With great respect and pleasure, I now invite Dr. A.V. Srinivasan sir to deliver his address. Sir, this is over to you. You can proceed with the next. Thank you.
Thank you very much, Ada Afishin. And it's very nice of you to have just given the cool words. And I'm indeed very fortunate to just share some of my thoughts with the people. And I'm going to touch very useful on the epilepsy. I'm going to touch on the classification of epilepsy. The world look at it as an easy way is localized or non-local. When you look at the localized one, it is called an idiopathic for which the known cause, or it can be asymptomatic and it is known or a suspected CNS disease. And the non-local, of course, is symptomatic. You have to go through a known cause. And one should be very, very careful. And the medical outcome depends on the risk of the recurrence after a first unprovoked seizure, remissions from seizures, relapse after drug withdrawal. Now, these are the three most important points. When you look at the prognosis, the overall risk of recurrence after 1 year varied between 13 to 16 to 36 among different studies. The risk is the greatest in the first year of the index. And the most important point is, 1 minute. Yeah, sure. And okay, thank you. And the risk of another seizure following a second seizure is 79% by the Camfield group in 1985, and the higher rate of recurrence in symptomatic than idiopathic. 10%, 24, 29 at 1, 3 years respectively in idiopathic seizures. 26, 41, and 48% at 1, 3, 5 years respectively in symptomatic seizure. This is a paper from Hassan in 1992. When you look at the prognosis of a first unprovoked seizure, risk of recurrence is more if the index seizure is A, status epilepticus, or B, complex partial seizures, where CPS, complex partial seizures, 78%, generalized tonic-clonic seizure, 44%. It's a paper from Camfield et al. Risk of recurrence is more if there is a previous history of febrile seizures. Risk of recurrence is more if the EEG shows epileptiform discharges. Normal EEG does not rule out seizure recurrence. Recurrence rate is 12% after a first unprovoked seizure with a normal EEG by von Dantzler in 1992. When you look at it, out of 100 people, when they have a known epileptic patient, it is believed that 70% only get the epilepsy attack, whereas 30% may not show in the EEG. If you take the normal 100 people, 5% may show EEG showing the epileptic seizures. So don't treat the seizures, but treat the patient depending on that. And the recurrence alone is more if the EEG shows epileptiform seizures. Then what about the desirable pharmacokinetic properties? This is very useful for treatment of the epilepsy patient. The pharmacologic properties must be complete or constant bioavailability to the patients. Availability of a parental formulation, elimination half-life, linear elimination kinetics, no auto-induction of enzymatic biotransformation, no pharmacokinetic interaction with other drugs, slow absorption or sustained release formulation, rapid penetration into the brain, and volume of distribution with single component, low and non-saturable protein binding, and no active metabolites. Once you know these facts, then what about the classification of the anti-epileptic drugs for metabolite? No major metabolites, predominantly monomechanistic is gabapentin and vigabatrin. No active metabolites, predominantly monomechanistic, ethosuxamide, oxcarbazepine, phenobarbital, phenytoin, and tiagabine. No active metabolites, polymechanistic is lamotrigine, topiramate, and zonisamide. So when you have this classification, the classification of AED, it is monomechanistic, but metabolites with anti-seizure activity. The parent is carbamazepine. The active metabolite is 10 to 11 carbamazepine epoxide. Polymechanistic with metabolites with no anti-epileptic activity, but with side effects. Parent is felbamate and active metabolite various. Polymechanistic but metabolites with anti-seizure activity. The parent is primidone and the valproate. Active metabolite is PIMA, phenobarbital, and other metabolites. When you look at the classification, the compounds that are inactive but are metabolized to drugs with anti-seizure activity, one should be aware of this is a parent oxcarbazepine and as well as fosphenytoin. The active metabolite is MHD and phenytoin, which are very useful as an anti-epileptic property. When you look at the common mechanism of the epileptic drug action, you look at it, the sodium channel maximum is phenytoin. Carbamazepine is once again phenytoin. When you look at it, the sodium valproate has got an inhibitory transmission. Ethosuxamide, of course, is calcium channels. Phenobarbital is once again inhibitory transmission. Benzodiazepines inhibitory transmission. And you find the lamotrigine actually, along with carbamazepine, is a sodium channel, and zonisamide has got sodium and as well as calcium channel. It has been believed that when you have a 3+ in the, especially pictures, it's a primary action. If it is 2, it is a probable action. If it is 1, then we can say it's a possible action. When you apply that rule, vigabatrin has got primary action, inhibitory inhibition, and then tiagabine is once again inhibitory transmission and is a primary action. And when you look at the 2, the gabapentin, felbamate, topiramate, and levetiracetam, when you look at it, of which except the levetiracetam, rest of them are all probable actions. Whereas levetiracetam, we have to think of possible action is there in the efficacy of anti-epileptic drug for a common seizure. You look at it is phenobarbital, phenytoin, and as well as carbamazepine and sodium valproate are very useful. When you look at the benzodiazepines, once again, gabapentin, lamotrigine, and oxcarbazepine, all of them are both partial and tonic. When you look at it, when you have 1+ in the bracket, which is called efficacy, plus and question mark is probable efficacy, and 0 is ineffective. If you look at the decabinate atonic seizure, it is 0. That means its effect is ineffective. Worsened seizures is question mark with the underlying 2 lines. When you look at it, you can easily see when it comes to the efficacy part, topiramate, tiagabine, and zonisamide, levetiracetam, felbamate, and vigabatrin, All of them are useful in both partial and tonic-clonic seizures. But when it comes to the myoclonic seizures, it is only topiramate, zoniazepam, levetiracetam has been taken off for very good action. When it comes into the unknown, of course, you have a question mark. The question mark is for felbamate for absence and myoclonic, and zoniazepam is for questionable for absence, and we also said felbamate is questionable in the myoclonic epilepsy. When you look at the success of the anti-epileptic drugs regimens in 470 patients with newly diagnosed, previously untreated epilepsy, seizures free on first monotherapy are about 47% with 222 patients. Seizure free on the second monotherapy comes to 13% only. And then seizure free on the third monotherapy is only 1%. Seizure free on two drugs is about 3%, and total seizure free is around 64%. This is very useful for our clinical practice. When it comes to the probability of seizures, of course, in undiagnosed epilepsy, according to number, 470 is 40%, and then slowly the treatment increases. What about the intractable seizures? Excessive burden, neurochemical plasticity changes, cognitive deterioration, psychosocial dysfunction, dependent behavior, restricted lifestyle, unsatisfactory quality of life, and increased mortality, all of them the factors that characterize refractory epilepsy. Optimizing the treatment outcomes for epilepsy patients who have not responded to initial anti-epileptic medications, the education and evaluation for possible epilepsy surgery, or a routine screening for depression using a reliable and valid instrument, systematic screening of anti-epileptic drug side effects using a reliable and valid instruments, and a careful selection of subsequent anti-epileptic drugs will really give a very good result to the patients. When you have what are the important concepts of seizure practice guidelines? This must be remembered for each and everyone in the practice. History. Determine if event was a seizure. B. Differentiate it from seizure mimics. 3. Characterize seizure type and frequency. The diagnostic testing that you should undergo are clinical lab testing to rule out metabolic disorders, drug and as well as alcohol evaluation, evaluate potential for cerebellar disorder in elderly, electroencephalogram, and then the imaging studies. It will be very useful for patients. And when you have an important concept of seizure practice guidelines when continued, indications for referral, indications for hospitalization, indications for surgery and invasive component, and medical treatment of seizures and monitoring parameters and indications. I always give a methodology for our hand. When you look at your hand, it may be coming etiology for the epilepsy. The thumb T represents really trauma, toxic, and tumor. Index finger I represents for the infection that can cause in the body can produce seizures. Or the middle finger is metabolic, probably liver and kidney. Everybody wants to have a diamond ring in their hand, so D stands for demyelination, and as well as, of course, is important is demyelination and as well as degenerative. Little finger is little flow or absent flow vascular cause, and the hand heredity is H is hereditary causes of epilepsy, and then the other point is NT is nutritional disorders. If none of these are present in a given patient with a fit, then we use the word either A, idiopathic, or primary, or a syndrome where still the fixity of the lesion has not been done in the international literature. Assessing the efficacy of the new anti-epileptic drugs, when you look at it, the initiation of monotherapy, it should be with a new drug versus placebo, the treatment arms, and the patient population should be new onset. These are all the easy guidelines for the patients who are practicing epilepsy treatment. This will be very useful. Once you have initiation of monotherapy, it can be a new anti-epileptic drugs versus the old anti-epileptic drugs as a new onset population. When you look at it, the other third is, of course, initiation monotherapy, how high dose new AED versus the low dose of AED in a new onset of cases. If it is refractory, especially conversion to monotherapy, adjunctive therapy, high dose new anti-epileptic drugs with low dose, and the new anti-epileptic drugs with placebo can be very useful in assessing the efficacy of the new anti-epileptic drugs. The principles of rational polypharmacy. Correctly identify the epilepsy syndrome. Select a drug that is effective for the epilepsy syndrome, has the least potential for adverse effects of the concern to the patient. For the teratogenicity, skin rash, and weight gain is most economical. Initiate the treatment with one drug. If seizures are not only partially controlled at maximally tolerated doses, consider polypharmacy. For the second drug, select one that has a different mechanism of action, the lowest potential for the metabolic interaction, and the lowest potential for adverse effects. And if addition of a second drug completely controls the seizure, consider very slowly withdrawing the first seizure after 6 months. Please note here, when the fits are controlled with the second drug, please continue the first drug. After 6 months, you remove it. And the more complete control. Carefully record the seizures in your book. If two medications do not completely control seizures, reconsider the diagnosis, or consider the surgical option, or consider the using more than two drugs in a given case, which will be very useful. And this is the rationale behind the polypharmacy. When you look at the combination of based on the drug interactions, what is least useful is carbamazepine with phenytoin. The rationale being, phenytoin induces the carbamazepine metabolism, leading to need for much higher dose of carbamazepine. When you look at the least useful is phenobarbital with carbamazepine, where the phenobarbital is a powerful inducer. Especially phenytoin and valproate, Psi 450 system is rational. Epilepsy, valproate and phenobarb. Valproate decreases the phenobarbital metabolism. Be careful. Valproate with phenytoin, the both complete for phenytoin binding sites, reducing the value of total drug level management. The least useful is the felbamate with phenytoin, carbamazepine, and valproate. Please note many drug-drug interactions are there, the rational. Useful. Gabapentin with any drug, there is no drug interaction at all, so you can safely add it. Valproate with lamotrigine. Valproate inhibits the metabolism of lamotrigine, reducing the dose, and the cost of treatment with lamotrigine comes down, and it is a very useful one. The most useful is carbamazepine or phenytoin with gabapentin, tiagabine, topiramate, and felbamate. Reason, widely different mechanisms of actions, hence you are very safe in continuing this combination. The least useful is the carbamazepine with phenytoin because of the similar mechanism of action, or tiagabine, gabapentin, and vigabatrin is once again the same similar mechanism of action. This can be in our clinical setup so that you are justified in using the combination for most useful and rational method. Possible method is valproate with felbamate or topiramate. Felbamate and topiramate have been associated with weight loss, and valproate with a weight gain, so you can easily do it. Least useful is the carbamazepine with valproate in women of childbearing age group, and valproate and carbamazepine both may increase the risk for spina bifida. Valproate inhibits the metabolism of 10 and 11 carbamazepine epixoxide, which may be teratogenic. So these are all certain very easy and calculative methods by which you can easily assess the adding of the drug. The potential advantages of new anti-epileptic drugs should be, it should be different mechanism of action, improved pharmacokinetics with less needed for therapeutic drug monitoring, fewer drug interactions, improved therapeutic ratios, fewer adverse events, improved tolerability in special population, and altered immunological profile. All of them give a potential advantages for a new drug. Monotherapy trials with newer anti-epileptic drug, which we can definitely see through very, very clearly, comparatively. All the study, you can just see the importance, especially with regard to lamotrigine, and carbamazepine is very useful drug. And The serious adverse effects of anti-epileptic drugs, the serious adverse effects of AED include idiosyncratic, dose-related, chronic, teratogenic, or drug interaction disorders. So potential advantages of the new anti-epileptic drugs are they are different mechanism of action. Two, improved pharmacokinetics with less need for therapeutic drug. C, fewer drug interactions. And then improved therapeutics ratio, fewer adverse events, improved tolerability in special populations, and altered immunological profile. All of them are all potential advantages. When you look at the pharmacological properties of the new anti-epileptic drugs, you really notice here it's very useful with regard to zonisamide, striapental, levetiracetam, and ganaxolone, because all of them elimination, the first three are due to the urine, and then the last one, the ganaxolone, through the fecal. And then the most important point is, if you look at it, the zonisamide blocks the sodium and T-type calcium channels, while striapental may increase GABA. Levetiracetam can really increase GABA, and ganaxolone also act through GABA. Now, these are all very important, but only thing is, you remember the efficacy, the refractory partial seizures come with zonisamide. Refractory partial seizures is refractory absent seizures, striapental is useful. Refractory partial seizures in photosensitive epilepsy in levetiracetam, whereas complex partial seizures with refractory infantile spasm, ganaxolone is very useful. The racemide, you can use it in refractory partial seizures, and losigamone, as suppose you can use it in the refractory partial seizures stimulated by the GABA A receptor and mediated by the calcium channel. Pregabalin has been identified and the refractory partial seizures, and rufinamide has also been included under the refractory partial seizures. The pre-treatment seizures and outcome. No, of pre-treatment seizures does not have a substantial impact on outcome. And the first seizure trial group of 1993 randomized the study to address seizures outcome between treated and untreated patients after an unprovoked seizure. The treated patients had only half the risk of a second seizure compared to untreated patients. When you look at the remission of epilepsy, various studies show remissions ranges from 50 to 70%, depending upon 1 year to 5 year seizure-free intervals. The group for the study of the prognosis of epilepsy in Japan showed a 3-year remission rate of 58%. Anegas et al. Used a stringent criteria of 5-year seizure-free interval, showed a remission rate of 65% in 10 years and 76% in 20 years. With respect to seizure-specific types, absent seizure, GTCS, simple partial, secondary gentleness, and CPS all had a remission rate, if you look at it, 68, 69, 50, 60, and 61 respectively. When it comes into the remission of epilepsy, generalized idiopathic seizure is one of the most important prognosticators of remission. Early age of seizure onset is consistent with the predictor of intractability. Factors having no prognostic value in remission include gender, race, family history, time between diagnosis and the initial therapy. The relapse after the drug interval is very important for our practice. Overall relapse rate varies from 20 to 36%. The children have got a lower relapse rate of 12 to 36%. 50 to 80% relapses occur during the medication interval. Mental retardation and abnormal neurological examination are associated with a poor outcome. The relapse after the drug interval, once again, when you read the quality of standards of the American Academy of Neurology published their recommendation for discontinuing AED is a seizure-free patient. The recommendations were based on a review of medical literature from 6796. The 9 factors related to the probability of a successful anti-epileptic withdrawal are the sex, the age, onset seizure, type, etiology, neurological examination, IQ, duration of seizure freedom on an anti-epileptic drugs, treatment regimen, age at relapse, and then the normalization of EEG. If you look at the relapse after drug withdrawal, seizure free for 2.5 years on AED, single type of seizure or generalized seizure, normal neurological examination, normal IQ, EEG normalizing with treatment. With all the above profiles, 69% chance in children and 61% in adults of a successful withdrawal. So when you are concluding, approximately 50 to 80% of the epileptics achieve seizure-free state with medical therapy. When it comes into the surgical outcome, the medical retractability and the concept is ill-defined. Of course, it's getting almost perfected in these present years. And at most centers, adults are considered to have a medically intractable epilepsy when seizures continue despite adequate monotherapy trials of two anti-epileptic drugs, with or without one trial of polytherapy over a period of 2 years. One of the monotherapies should include a newer drug. What are the procedures that are available in the world literature now? Focal cortical hemispherectomy, corpus callosotomy. The first two aim in seizures for removing the brain that is responsible. They are appropriate for the symptomatic localization of epileptic seizure. Corpus callosotomy alleviates only the intensity and the severity of the seizure. The other surgical procedures like multiple subpile transaction, gamma knife surgery, and deep brain stimulation of DMAS, that is dorsal midbrain anti-epileptic zone. When you look at it, there are three approaches: anterior medial temporal lobectomy with amygdala hippocampectomy, amygdalo-hippocampectomy only, anterior temporal lobotomy with especially the most important, without hippocampectomy. When you look at the results of the temporal lobectomy, all the three procedures reported remission rate of 60 to 80%. In Weiser series, 61% were seizure-free and 6% had a rare seizure and 16% had a worthwhile improvement. In overall, 83% benefited from this surgery of the temporal lobectomy. Results of temporal lobectomy, Aruda et al. In 1996 compared the outcome of the procedures and declared no significant difference. EEG telemetry with intracranial depth electrodes recording a resectable seizure of focus which could be localized by scalp EEG recording, now more often identified. So et al. In 1989 addressed the issue bitemporal epileptiform abnormality detected on intracranial studies. Only 29% of the patients achieved complete remission. When you look at the comparison of all the 71 patients with anterior temporal resectomy, it has been clearly shown that it is very, very useful in the procedures. When you look at the profile, mood state, and then they employed in the school full time, all of them, when you look at it, it is a very good response for the patients to have their surgery. Univariate Pearson, especially correlation coefficient for ESI 55, composed scale scores with clinical variable more than 1 year after epileptic surgery on the various aspects of employment, driving, AED free and seizure free, etc. Of course, most important thing is the age and the post-operative performance and post-operative verbal. All of them have a very significant level in this. The neuroimaging studies, the most consistent MRI features are diagnosing hippocampal sclerosis or volume loss or hyperintense signal changes in T2 weighted sequences. If no MR abnormality was observed in surgical candidate, the post-operative success rate dropped to 44%. The PET showed 60 to 90% hypometabolism in the affected temporal lobe in immediately refractory mesial temporal lobe surgery. In ICTA-SPECT consistently demonstrated a characteristic pattern of global temporal hyperperfusion with relative decrease in the perfusion in the others. Ojman and Dodrill in 1995 found that the degree of postoperative memory was related to the extent of the lateral temporal resection rather than the medial resection. They noted that the preoperative verbal memory of performance was reflective into the extent of medial temporal lobe, and which clearly showed the pathology, whereas the postoperative medial memory deficit were dependent on the extent of the lateral resection. Visuospatial memory improved significantly with dominant temporal lobectomy. quality of life, the employment, the functional independence, social interaction, and sexuality are as important as the seizure control and cognitive function. Cognition is perception plus thinking. Now, twofold differences in the unemployment in Rochester study among the epileptics. Further studies are needed in these areas where you have to see how far the quality of life and improved in the epileptic patient. Hemispherectomy has been done with the Rasmussen proposed functional hemispherectomy in 83. About one third of the hemisphere, usually the frontal and then the occipital, are left with intact circulation. In 1998, Tinuper et al. Proposed modified functional hemispherectomy, which included corpus callosotomy in addition. Inclusion criteria for severe rehabilitation from the intractable episeizures and hemiparesis. 75% of the patients undergoing functional hemispherectomy became seizure-free, showed improved behavior within 1 to 2 months of surgery, and no change in intellectual quotient. So corpus callosotomy was also very useful, and this procedure is beneficial in a selected group of patients who have frequent generalized seizures with injuries and falls affecting them. So, in conclusion, 5 to 80% of the patients with epilepsy achieved a seizure-free state with medical treatment. 20% of the patients with partial seizures are medically intractable. Of this group, approximately 15% may be helped by surgery, with 60 to 80% of these patients achieving good seizure control with cortical resection. Only a small subset of patients remained who cannot be helped, for whom the newer anti-epileptic drugs which we discussed on the horizon may show a glimmer of hope. I just want to say thanks to the people to just listen to me. I always say that read not to contradict or confute, but not to believe or take it for granted. Please weigh and consider the thinking process of this particular epilepsy. Now, in epilepsy, 7th is the due date, and epilepsy, everybody should be given a good hand for them. And we must almost remember that epilepsy is only a point of thinking where in each and everybody should show their love and affection and give them a very smooth and as well as a very nice life in their the quality of life. If it is improved by our treatment, that is the day in which it's a real day for the epileptic patients, which gives immense value to the happiness of the doctors. Thank you very much.
Okay. Thank you so much, sir, for this wonderful session, sir. With all your permission, so shall I take question one by one?
Yeah, sure.
Okay. So the first question, sir, in your vast clinical experience, sir, what are the most commonly missed early neurological signs that general clinicians should be more vigilant about?
No, see, when you look at the patient, the first thing is if they have a loss of consciousness of more than what I call it as a 30 seconds, it's 100% epilepsy. If there is a no loss of if there is a loss of consciousness for 3 to 5 seconds or 10 seconds, please don't think it is epilepsy. Think it could be a cardiac cause where there is a especially change in the heart. The second one is you must look at the eye. The eye may go up or go laterally, and then the patient is opened up, and then if he doesn't react, then we can say that it is definitely a possible epilepsy. Third, some people, they look at the light, or there are some reflex changes that can produce reflex epilepsy. For example, if there are some people, when you continue to look at the, especially the lights flickering, then they can get the fits. Then the other thing that one must be look, some people get reflex epilepsy even to when they are looking at the light, or when they are doing even mathematics, then they can get the epilepsy. And one should be also thinking of the eating epilepsy where one can get this. All these things, clinical clues. But I always say, look at the eye, look at the hand. If they have a single movement of the hand or a single movement of the eye, it can be a focal onset. If it is going to be a generalized onset, then they lose their consciousness. So we have already told you how to look at the etiology in your fingertips. So by and large, the first step, is it only one side or is it on both sides? Second, is it going to be loss of consciousness of more than 30 seconds? Three, the eyeballs going up. Four, of course, you can send the blood test and then prove that the patient has got a epilepsy. So for practical purpose, I think you must divide them into case with the reason, then you call it as a secondary epilepsy, or it can be a primary epilepsy where it can be an idiopathic one.
Okay. Thank you so much for
Yeah.
this brief answer, sir. So the next question is, sir, what practical approach would you recommend for primary care physician?
Primary?
Care physician.
Oh, the primary care physician first. As I told you, first the duration, the clinical manifestations will be helpful. Second, please ask them to do the whether there is any family history of epilepsy, because with them they can easily find out. Third, most important is in their childhood, if they have a fever and then the fits, those patients have got increased chance of getting the attack. So you must be careful. And
Mm.
third is, of course, when you are really for a practitioner, let him have a sleep between 10 and 5. Reason, between 11 and 4, the the brain prepares the body for the next day. So the neurotransmitters are not properly, if they are going to be in the night and then doing some work, or doing some work, then they can get into these problems. So second, some people are allergic to especially certain drugs, so you must be very careful that they can get seizures. Third most important point is they should be very, very useful and never miss the drug when they are given. And four, please do the EEG and look for the epilepsy records, because if you see epileptic records, there is a chance for him to get increased attacks of seizures. So as a practitioner, general practitioner, when I see, I give all the ask the details and then refer them with all the investigations to the consultant, and so that he can start the anti-epileptic treatment.
Okay. Thank you so much, sir,
Thank
for
you.
sharing your valuable and wisdom and clinical insights with us today, sir. With all your permission, sir, shall I conclude this session, sir?
Yeah, please. Thank you very much. I'm indeed very happy, and sorry I couldn't just do it yesterday. My thing it just became very interesting. Now it has become easy for me to do it today.
Sure, sir.
Thanks my assistants and everything have been received today.
Okay, sir. On behalf of IGCP, sir, I extend our deepest gratitude to you, sir, and to all our participants for joining this special session on International Epilepsy Day. It has truly been an honor and a privilege, sir. Thank you so much, sir.
Thank you.